So we did tachycardia. Okay, so it's kind of similar. So first of all, what's the normal heart rate?
60 to 100.
60 to 100. Okay. Remember, this 60 to 100 is like, it's a spectrum, right? So there are some people who are here and some people who are here. So it depends really on the person, but like, 97.5% of the population are 60 to 100. Okay. So this is usually in the inpatient setting. So you're gonna, get a page from the nurse. Patient X is bradycardic, is Brady. Okay. And sometimes it will tell you patient's heart rate is in the 30s, for example. Okay. Remember the reason first of all, the reason they tell you, even if the patient is not symptomatic, the reason they tell you is first, they have protocols that they have to follow. So they have to tell you, they have to let you know that the patient is bradycardic, or they have trigger points where they have to tell you. So the first part is just for the nurse, they usually document something like MD aware, that my responsibility is done. I told them, the MD, that the patient is bradycardic. Okay. And usually when they tell you that the patient is bradycardic, usually the patient is already on telemetry. Okay. Because otherwise they wouldn't be noticing. What happens is that the telemetry thing starts beeping that patient's heart rate is like 35. And so they tell you patient is bradycardic. Okay. So what's the first thing you're going to do when patient is bradycardic? Go see the patient. Me personally, before I assess the patient, I assess the tele. Okay. Unless the patient is like crashing or something. And based on the tele, I at least have a bradycardia diagnosis about why the patient is bradycardic. Okay, because there's a whole bunch of diagnoses that you should know, and then we'll review them actually here. But before you assess the patient, you want to go with an idea about why the patient is bradycardic in the first place. Okay. Then what you want to do is assess the patient. You want to go see the patient, and what is something specific you want to assess the patient? What do you think? So if somebody is bradycardic, you're going to go see them. What's a very common cause of bradycardia? Let's say it's 2 a.m. Anybody knows? So sleep. So you really want to assess if the patient is sleeping or not sleeping. Okay. And it's really simple, because if they're sleeping, okay, I want to say that, for 90% of the time, just let it be. Because it's usually an asymptomatic bradycardia in the setting of sleep, and you don't need to do anything. Okay. But if they're not sleeping and they're actually bradycardic, then you want to question mark if there is symptoms of bradycardia. If they're having any sort of lightheadedness, if they're having any sort of visual problems, any sort of symptoms, and plus you want to check their vital signs, and specifically you want to check their blood pressure. Okay. If they're asymptomatic, if there is no symptoms, plus normal blood pressure, so stable bradycardia, then I would say let it be. It's fine. Okay. Because you don't act on asymptomatic bradycardia, even if it's in the 30s, you don't need to do anything. Okay. So this is easy so far. If it's unstable or they're symptomatic, then you need to treat. And the treatment depends on the cause. Okay. So let's go with the causes kind of one by one about bradycardia, because every cause has a different therapy. Okay. So what are the causes of bradycardia? Common causes, not all causes. Okay. So we mentioned the first one is sleep. Okay, sleep is a common cause and you don't care about it. Okay. The other one is if the patient is baseline athletic and their baseline heart rate is like 40, so they'll be bradycardic. So these people, you know, these things you don't do anything about. What's another common cause? Somebody in the hospital is having bradycardia.
Beta blocker, calcium channel blockers, meds.
Yes, exactly. So the big one is beta blockers. Okay, so you really need to check the meds that they're on. Okay, and if somebody is having beta blocker and they're bradycardic, how do you treat that? Any idea?
Glucagon.
Glucagon, very good. So glucagon is the antidote for beta blocker toxicity. So you give them glucagon, and that will kind of mitigate. That will help. The other causes include if somebody is having a vagal, like kind of vagal causes. Specifically, it's not really vagal stimulation, but it's vagal stimulation secondary to something. And some people might have this syndrome called carotid hypersensitivity. I can't write it. Okay, so carotid hypersensitivity just means their carotid sinus is hypersensitive for whatever reason, and they're getting a lot of vagal episodes, and these people will be symptomatic and they will be bradycardic. In this setting, you know what's the treatment of choice for carotid hypersensitivity?
I mean, just loosen up the, I mean, like, if there's anything tight around the neck.
But they have nothing around the neck. They just have hypersensitivity. And the way you diagnose it is actually you give them carotid massage and you watch the telly, and they will have a pause. The heart stops beating for a while, and then until you remove your hands, you get back some rhythm. These people, they're very highly symptomatic, and these people will need a pacemaker. So you usually place a pacemaker for them because they're just going to be symptomatic and it's not going to get any better, especially if it's idiopathic. Okay. Now, if somebody comes in, especially in the ICU setting after a surgery, specifically if somebody comes after post-carotid stenting. So these are the people you might want to think about, because these people will have a stent and the stent might compress the carotid sinus, and these people will have bradycardia. Okay, so it's usually self-limiting after the stent, but if they're symptomatic and you need to do something about it, what can you do? What can you give? Somebody's bradycardic, how are you going to get the heart rate up?
Atropine.
Atropine, exactly, atropine. Or here in this setting specifically, you can do a dopamine drip in this post-carotid stenting because it just helps. All right. And then finally, the most important one for you to know and recognize is heart block. Okay. And heart blocks, so multiple types of heart blocks. If somebody is having a new heart block, what are you thinking? What's your differential diagnosis right away? What can cause a heart block, guys?
Could it be an MI?
Very good. So ischemia has to be in the top of your differential. Okay. So either new ischemia or old ischemia, but you worry about a new ischemia. The other one is infections. For those of you coming to the Northeast, what infection causes heart block? The famous infection. I know you know it, guys. Lyme disease. So Lyme disease is a very common cause of heart block in Northeast. You guys going elsewhere, but you never know. Last weekend I was in Connecticut hiking, and now I have bradycardia. it could be Lyme, so you can test for it, okay? So I'm just gonna review with you the heart blocks since we're talking about it, okay? So let's talk about, so what types of heart block? You have, you know, first degree heart block, and you have second degree heart block, 2 types, right? Mobitz type 1, Mobitz type 2, and you have a third degree heart block or complete heart block, okay? So remember, in first degree heart block, there is no dropped beats, right? In second degree heart block and beyond, or really not beyond, because third degree is different, there's dropped beats. And then in third degree heart block, it's complete heart block, okay? So first degree heart block just means that the PR interval is prolonged, okay? So, you know, you have an EKG, and then this is kind of how it looks like, you know? This guy is prolonged. Easy. And there's no dropped beats. Remember, no dropped beats, okay? If you see a dropped beat, then it's something different, okay? In Mobitz type 1, which sometimes they call it Winky-Buck heart block, there is a stepwise increase in the PR interval, and then there is a drop beat, then goes back to normal, right? So the PR interval is like stepwise increasing in size. So you've got a normal, then you've got little extended, and then you've got a drop beat. Then you get to normal. So you get this drop beat. Okay? Simple, easy. Second degree heart block type 2, Mobitz type 2. Usually in this one, you might have a PR that is prolonged, plus you have a 2-to-1 conduction or 3-to-1 conduction or more. So you will have random drop beats. So you will have a prolonged and then a drop beat randomly, and then another drop beat. So, you know, see this guy, this is dropped because there's a P wave and there's no QRS, okay? So this is how you look at it. So sometimes it can be 2-to-1. So this one, like this section here, this segment here is 2-to-1, right? There's 2 P waves and 1 R. Okay, this segment 2 is also 2-to-1. Okay, so when you see 2-to-1, think about this not Winky-Buck, sorry, type 2, Mobitz type 2. And then finally, complete heart block. Complete heart block is just, there's no association. There's like essentially no association between P and R. Okay, so you've got, you know, the P marching, and then you got a QRS, then P, then maybe another P, then QRS. And the thing that you need to know here is that, you know, there's a phenomenon called P on T. You know, the P comes on the T wave. So that's how you know, like there's some things that you need to know, but essentially the R wave is marching by itself, and then the P wave is marching by itself. Okay, simple. So why do you need to know this? Because treatment is different, right? So for first degree heart block and second degree type 1, which is Winky-Buck, what do? What's the treatment?
Nothing.
Nothing.
Right.
Yes, nothing to do, NTD, unless symptomatic. While second degree, the type 2 and third degree, how do you treat it?
Pacemaker.
Pacemaker, exactly. Okay, so this is the line between pacemaker and no pacemaker. Okay, so it's very important to distinguish between, especially these guys, you know, because it makes a difference for the patient. You're gonna either send them for a pacemaker or you're not. Okay, so this is like for you to diagnose, right? And to treat. Now, you can treat the underlying cause, but sometimes you don't have enough time to treat the underlying cause. Sometimes, the patient becomes bradycardic and is unstable or needs to be treated fast, okay? So let's say this patient has heart rate 30 and blood pressure 90/40, okay? Or symptomatic. Okay, so either low blood pressure or they're symptomatic. How are you going to treat the actual bradycardia? So what you can do is, first, as you mentioned, you can give atropine. How much atropine do you know? So you give 0.5 milligram IV, okay? 6 times max. So essentially 3 milligrams is the max dose. Okay, so you run out of atropine. What's the next? What else can you do? Another medication.
Right.
So we talk. Say it. We kind of talked about it. You can do dopamine drip. That will increase their heart rate, specifically, post-carotid stenting, or you can do epinephrine drip. Let's decide. What do you think? Cards, exactly. So usually the cardiology fellow should be involved once things get this dicey, and they will be managed there because they might need transcutaneous and maybe ultimately transvenous pacing and then maybe an actual pacemaker before they get discharged. The most important part, by the way, of all of these, we forgot to mention, especially if you have heart block, what do you want to do to confirm? EKG, right? You have to order an EKG. If you're concerned about the patient, just get an EKG, a 12-lead EKG, okay?